that, but the correct terminology. Now, if you look at the MHPSS needs, it's important to realize that those very broad, and they go from social problems to more psychic or mental problems, and they range from problems that existed before the emergency to problems that are caused by emergency to problems that are caused by the way we respond to the emergency. So you see some examples here. For example, discrimination or marginalization of specific groups really happens before an emergency and is often continued after. That itself causes problems, particularly social problems, families that get disrupted, people lose their livelihoods, people that are forced in all kinds of illegal activities or maybe abused. Then there are problems more in the mental health field. Important to realize that this does include problems that already pre-existing, particularly severe mental disorders such as psychosis, bipolar disorder, as well as substance use problems. Of course, also includes emergency-induced problems such as PTSD and depression. And lastly, some of the mental health problems and the psychosocial problems of people are actually related to the way we respond to their needs. People ask us in UNHCR about numbers and percentages, and that's difficult because we don't have very accurate information, but we have good estimates. These are the estimates worldwide in a non-emergency setting. We say around 2 to 3% of the people have a severe mental disorder, 10% have a mild to moderate mental disorder. And in an emergency setting, we see that groups change. Mental disorder rises with 50%, double, and stress, that's the third category, increases a lot. In fact, in the immediate aftermath of humanitarian settings, when new refugees arrive, everybody's distressed. And important because you may easily conflate generated distress with mental disorder, which is not. To make it even complicated, this is another guesstimate where we look at the distress levels of refugees. And what you see in the beginning, distress levels are extremely high. But usually when things get organized, communities get their act together, people help themselves, it goes down. But what we are faced with in UNHCR is that in many of the settings where people live for years, for decades sometimes, the distress goes up again. So we see in protracted settings is that the distress really goes up. Very roughly, and how to address these needs? Well, in the past, we've done things that were not so good. So we learned it the hard way. For example, in the past, not so much these days, we had the idea that maybe everybody was traumatized and everybody would require psychological therapy or counseling. We focused too much on things that happened while ignoring the daily life stress that refugees have now. Disproportionate amount of resources may have gone to screening and identification without actually having the opportunity to provide decent services after it. And the fourth point, which is a very important one, is we used service models where we did things, interventions for people rather than collaboratively with a sense of concern. And lastly, there is a tendency in humanitarian emergencies due to the enormous pressure and enormous need to create parallel services, which is to an extent logical, but it has a danger in itself to, in the end, create more havoc than we want. Now, this is all the past because we have guidelines how to do it. The famous ISC guidelines that were issued in 2007. If you're not familiar with it, look at them on the internet. elements that is central in the IASC guidelines is this pyramid. I think many of you are familiar with it, but I still want to show it because it's so important to our work. What you see here is a public health pyramid, which with 4 levels of services. And the basic level, level 1 on the bottom, actually is the work that is done by any humanitarian practitioner, no matter what, shelter, water, sanitation, food. Those people have a tremendous impact on well-being, positive or negative. So we need to involve them in doing work in a good way. Level is about social cohesion, about strengthening self-help and family support. This is not so much a health field. Me as a doctor, I'm usually not involved in this. This is usually in UNHCR done by community services or protection. But to me, this is the base of good mental health work. Go to level 3, focused person-to-person support, but provided by non-specialists. Given the enormous magnitude of the problem, it's impossible to provide specialist care to everyone. We need to do what we call task sharing. Train non-specialists in specific tasks, well supervised, to address MHPSS needs. And then, of course, we have the level 4, the clinical services that some people need specialist services, and we make sure that those ones who really need it also get it. UNHCR, based on these principles, we have made an operational guidance on MHPSS program in refugee settings. But actually, if you look carefully at the evidence that we collected, it's mostly still based on camps, refugee camps. And we have limited information about how to do it in urban settings, and we need to change that. I'll go to the second part of my talk, and that's refugees. Is that in the last decades we said the global refugee crisis and the burden is urbanizing. These people, the money now is in urban settings. We had the point of change a few years ago, and we see now every year that the share of urban refugees is increasing. So it's not an atypical special situation. It's getting more and more the norm. This is specific problems. Refugees in urban settings are to some extent different than the ones we find in camps. In camps, you often see whole families that are displaced. In refugee settings in urban context, we often see more fragmented earlier systems. And there is a kind of self-selection process in which some people go to urban settings and others stay behind. We need to speed up a little bit in time. Within HCR, we have realized the importance of urban refugee settings. So we have since a few years a policy, and here are entering. I've picked out just 4 elements that UNHCR recommends in general. This has nothing to do with mental health per se, but in general, how to engage with urban refugees. The main problem is where to find them. In a refugee camp, it's easy to find the refugees because they're in the confined space of a camp. So if I want to provide services or I want to discuss things with them, I know where to find them. In an urban setting, this is very different. So what we need to do is a way to connect with them. And the best way to do that is use refugees themselves. Train refugees, outreach volunteers who are able to keep in touch with other refugees, to liaise with service providers. If there is no physical space for community, we help refugees to create that through, for example, community centers where refugees and, if possible, other non-refugees can come together and socialize or follow courses or get treatment if needed. Way of reaching refugees by health messages is not always the best in the urban jungle. So again, here we need to keep in touch with refugees by using out-of-the-box methods, such as using cultural events or neighborhood meetings where you can do refugees. Now, this is setting the scene. So I hope I've shared a little bit with you about what MHPSS is, to the increasing importance of the urban context. So now we have to put those together and to see how can you do good MHPSS programming in an urban setting. We haven't seen yet at the moment, and there is still a surprisingly limited documented evidence on good practices. But I want to share a few things. Malaysia. I went to Malaysia a year ago, and interesting in Kuala Lumpur, a major town, is that refugees face a lot of protection threats. They're not able to legal jobs. It's not allowed, which means that they're very vulnerable for abuse and for discrimination and marginalization. The nation in Malaysia has done several things to work with urban refugees, and one is to create mobile information hubs, for example, in churches or in other community centers. There is a vast network of refugee volunteers. There is a vast network of refugee interpreters. And there is, and that's the next point, there is an initiative called Social Protection Fund, which funds small projects by refugee communities. This is very much related to layer 2 of the IS myth that I just showed you, creating social capital, creating cohesion within refugee communities. A few things I want to say about Malaysia. Maybe we can discuss more later in the discussion. The second example that I want to give is Syria, and not so much the Syria of, but the Syria of a few years ago, when actually hundreds of thousands of Iraqi refugees went to Syria to find refuge. UNHCR has done an innovative project in that period to work with urban refugees. It's still ongoing, but the documentation is about the program with Iraqi refugees. And well, you can read here the main elements. Again, the main is to work with outreach volunteers. And you see the tasks that they have, and you can see, well, you could paraphrase it as para work, I would say. And they're social workers, but non-professional social workers. They're professional, but they're not professionally trained. The Syria had a bit more than only it also consisted of management for people with more complex mental health needs, for example, chronic mental disorders, or people who were so affected by the horrible events that they had experienced that they couldn't cope and they could fend for themselves. So case management was the second element. And the third element was capacity building within existing systems, particularly the health system. So training doctors, nurses, psychologists in dealing with refugees. So this, lots of training. I will go through all the details. But basically it means that in all the 4 levels of the ISC pyramid that I showed you, you need to organize trainings of different kinds because the goals are different. I'd love to talk more about all this, but I have no time. But you can read. This is, and that's why I mention it, this is one of the programs that has been very well documented. So you can go to the website of Intervention Journal, and in November 2013, And in November 2011, several articles have been published on this program. It's really inspiring. Then, quickly, I was in South Africa a few months ago, and there were really good initiatives in the context of the major urban towns in South Africa. And one of them was an NGO called Future Families, who again had a system of case management combined with good outreach work and task shifting, and get refugees themselves in helping other refugees. Example is Egypt. Actually, the elements that I gave you will see again here in this program, which is ongoing and is actually vastly expanding. The challenge are to those in the other settings. I mean, this is a picture of Cairo. The right part is what we usually see on the postcards, but the left part, the major urban slums, millions and millions of people, that is where most refugees are. Well, where to find them? How to find them? How to engage with them? That's a major challenge, and local NGO started about 6-7 years ago to address the psychosocial issues, and the NGO is called PSTIC. And you may be able to find documentation about it on the internet as well. The background of the program is social work by refugees as para-professionals. The important element here is that those refugees are not just employees of the program, but they are actually rooted within existing community-based organizations, such as schools, churches, or local NGOs. Now, if I social worker, PSW, people think of talking with a client to solve the problems that are located in the mind of the person. That's not really what the psychosocial workers in Cairo do. What they do is help refugees to find good to use existing support systems. So it is navigating through the urban jungle, and that's a skill that outreach workers and community-based social workers need to know. Support is not just talking. People have many problems, and that may go from health problems to financial problems to problems with housing. If you're not able, as a psychosocial NGO, at least recognize these issues and assist the client in finding solutions, you get about the more psychological elements. This is more or less what I wanted to say. My last slide is about operational guidance that UNHCR has made a few years ago, actually 2 years ago, for mental health and psychosocial support in refugee operations. It's largely geared to camps, but we hope that the next version, with initiatives that I just showed you, be more towards urban settings as well. A few things here. If you have mental health and psychosocial programs for urban refugees, you need to, 1, engage very actively with refugees and not just do services for refugees and hope they will come. 2, make holistic, which it can go about anything. 3, ensure your service provision is integrated, not a standalone psychological service, because people won't easily come. 3, use task-sharing approaches, which is train non-specialists in doing tasks that otherwise would be done by specialists. This is well known through the MHPSS program of WHO for the health sector. But I would also like to flag the psychosocial mechanisms, for example, interpersonal therapy, that can very well be trained to specialists in quite easy ways. And lastly, facilitate access to existing services in the host country and advocate refugees can use them. For taking too much of your time, I hope some of you have questions or suggestions. I would love to hear more, and I would love to hear good practice examples from you guys, so we can use this in future documentation. Thank you very much.
Thank you, Peter, for that very interesting presentation. So 2 minutes left now for questions. We have a couple that have already come in, but if anybody else has a question for Peter, if you can message me using the chat function, and then we can ask him. Okay, so Peter, the first question we have here is more on data. So the question is, what steps can be done to address the shortage of data on mental health outcomes for refugees? And the person posing the question asks whether data from the brief mental health screening that is completed before arrival in some countries of refuge could be collected in a systematic way by UNHCR or IOM to get a better understanding of the types of mental health problems refugees might be facing. On to that.
Thanks. I have 2 issues here in this question. One is a question of outcome data, and the second one is about seeing refugees in resettlement processes, which is actually another issue. I will say briefly something about both issues. The first one about outcome data. This is a major weakness within the MHPSS field in general. We're not very good in monitoring the effects of what we do. And this is our attention in the next years. Within the ISC reference group for mental health and psychosocial support, we are now developing a common monitoring framework. Because that each program, each NGO, each donor has its own monitoring system. And most of the monitoring data is about output data. How many clients have you seen? How many groups have you done? How many flyers have you distributed? Well, actually what we are interested in, of course, is what are the effects? What is the outcome? Or what is the impact of what we do? And what I try to do in the ISC reference group is to develop a common framework so that we can more easily collect data over different context and through a wide range of different interventions to more easily compare. Still not there. With still, MHPSS still is a relatively young field that still strives to remain a unit field. So that's what I would like to say about the first point. The second point about whether IOM or UNHCR could routinely collect data to guide resettlement processes. Here I'm not really sure what the question entails. I think we should massively use screening tools for refugees while they're still in the countries of refuge, so in Africa, for 2 reasons. One is I'm not impressed by the existing screening tools. Usually those are brief screening tools, self-report questionnaires that may with disorder and also not always be contextually relevant. So there are lots of methodological challenges. Secondly, there is an ethical point. There are concerns within UNHCR that documenting abilities of people may in the end work against the interest of refugees. For example, people not being resettled because they have a severe mental disorder or because they are suicidal, for example. This is something we need to think through. What I do think is important is to understand the needs, the psychosocial and mental health needs of refugees, and my advice would be to do that through qualitative participatory method. So talking with refugees, sitting with them and documenting their problems, both before the resettlement as well after the resettlements when people have arrived in their new country. Ken, is this a little bit of an answer? Or actually, you didn't ask the question. I don't know who asked the question, but perhaps the one who made the question can respond.
Yeah, if the person who did answer that question wants clarification or wants to respond, please, just let us know. just whilst waiting, I'll just add a little bit to what Peter was saying in that very much I sort of agree with him from my own experiences that the idea of using screening questionnaire has ethical concerns and also sort of practical concerns as well. The other thing in terms of understanding the mental health issues that refugees might face, there's a fair amount of literature on this subject, particularly from sort of high-income countries, that gives us at least maybe a good enough indication of some of the difficulties that people face, and it's perhaps through more research like this that we might get an understanding. I don't know if anyone else if the person who wants to ask the question wants to respond or get more clarification. So I think we'll move on to the second question. So Peter, the second question is, in resource-poor settings, what can governments, local health and social services do to support refugees living in urban settings? You might have covered some of this in your presentation, but if there's anything else you'd like to add, please do.
Yes, well, I hope I addressed the issues in my talk, actually. But one thing I may have insufficiently highlighted is the responsibility of state institutions, so existing services for healthcare or social services. One of the things we can do and should do, particularly as UN agencies and as NGOs, is to advocate that services are available for refugees. What we see in many countries is that either refugees are not allowed services, or secondly, when they are allowed, the policy is not implemented. For example, in South Africa, we see that the law is excellent. Any refugee can use the health system, largely for free. In this DAO, there is discrimination against migrants and refugees from sub-Saharan Africa. So I think it's very important to refugees understand their rights, and what the program in South Africa is doing, with brochures, with meetings to inform refugees about their rights, as well as inform service providers that refugees do have the right to get services. So advocacy is an important issue here, and well, sometimes, of course, we see that agencies are overwhelmed. I recently visited the Kurdistan in Iraq last week, and what we could see there, that, for example, in the governorate of Dohuk, 1 million inhabitants, that they had an influx of no less than 1 million refugees and IDPs, internally displaced people. Well, this, of course, is a massive burden on the existing systems, including the healthcare system, and the government needs support. So I think the first thing that NGOs and agencies need to do is to strengthen these existing systems so that they are better able to deal with this influx of refugees. What you already see in Kurdistan as well is that the tendency to create services, and that's something we should not do. So that NGOs poach good services, work with them in refugee settings or in IDP settings, and in way actually undermining existing services. And that is actually a recipe for trouble, because in the end the local host populations will become disabled, and the governments will become unhappy, and it may impact your whole response. So an element that I have not highlighted sufficiently. So thank you for giving me the chance.
Thank you for that, Peter. Now, we haven't had any more questions come in, but we have with us today Dr. Mark van Omeren, who is the focal point for mental health and emergencies here at the WHO headquarters in Geneva. So I'd just like to hand over to Mark to see if he's got any comments on this topic in general and urban refugees, mental health of refugees in urban settings. So, Mark, over to you.
Thanks for that, Ken, and thanks for a great presentation on a very important topic. Peter, a question. In the IEC guidelines that you mentioned, there was no action on case management. At the time, there was not a consensus on case management. So the guidelines being an interagency consensus-based product, case management didn't make it into the guidelines. Now, you mentioned in a variety of cases the word case management and as a strategy, which to me makes a lot of sense. Now, I'd like to have your views on this. Do you think case management is something specific to urban refugees, or of course it's not specific to urban refugees, but is it something that's specifically useful for refugees more than in camp settings, or is it something that in general should be part of the global policy that we have on mental health and psychosocial support in humanitarian settings?
Good question, Mark. Thank you for this. Let me unpack the issue a little bit. I think the principles of case management, so case management principles, are important in almost all MHPSS work, because it's a matter of helping conflict-affected people to find the right of supports and the right services. With a case management principle, you need someone to manage that case, to help the person navigate through the system. How there are differences between camp and non-camps and urban setting, because it's much more difficult to find the right services when you're in an urban jungle. So yes, I would say particularly in urban settings, it's important to use these case management principles. Number one. Number two is, do we need case managers? What is a case manager? Sorry, I hear lots of sounds now. Yeah. Do we need case managers? There are several NGOs, the International Medical Corps is of them, who has beautiful programs with managers, for example, in Lebanon and in Jordan as well. However, this is in relatively high income settings, higher middle income settings. I'm not sure we have sufficient evidence yet to recommend doing this all over the various refugee settings, for example, in sub-Saharan Africa. So I think this is definitely a topic where we need to gather more information. And I tell you that the journal Intervention, which I used to edit in the past, is preparing a special issue on case management in humanitarian settings. And if people among the audience have good experiences in case management, using case management principles in MHPSS, please think of documenting what you do, because I think the level of evidence that we now are is low. So the first thing we need to do is to document exactly what we did and what the experiences are. Then hopefully in next stages we can go a step further to really go to, for example, to see whether we can do trials, randomized trials. But I don't think in humanitarian settings we are there yet. Is that somehow your question, Mark?
Yeah. Sorry, muter. It's not doing what I wanted. Yes. Yes, no, it does answer my question. I was thinking that mid-Sub-Saharan Africa, one could build in intensity forms of case management. One could find roles of, as you call them, parasocial workers who would do similar things. of that?
No, absolutely. That's what I actually tried to say with using case management principles. So you may, for example, use either community-based parasocial workers or community health workers or perhaps SBV outreach workers to do case management. And that is different from the case management in lower middle income countries with much more complex systems of services and where you sometimes need people with a university degree to become a case manager. So it's very context dependent. And a thing I haven't mentioned yet is the cost. I think we should also look at what is the cost effectiveness of these approaches. I don't yet, but this is absolutely something we need more evidence about. And yeah, let's have a similar talk a few years from now. We can provide yes, but I don't have them yet.
Thank you.
Okay, thank you, Mark and Peter, for that. So we're nearly at time, but we've just had another clarification to an original question come in, which I'll read out to you, Peter. Maybe if you can just maybe expand a little bit on this. So this was regarding the comments about screening. And so the person was particularly thinking about the required pre-departure mental health screening that is already conducted by the Department of Homeland Security of the USA. So the USA already conducts these screenings before refugees arrive in the USA, and probably some other countries have similar practices. So given that this is already conducted, is there any way that we can utilize these data and better identify refugees who may exhibit risk factors? So not just those with disorders, but given the context of displacement and social support, to better track refugees and their outcomes. So I suppose maybe like using some of the data in terms of a sort of longitudinal study or not. I don't know if you've got any further comments on that, but if you have, that'd be great to hear them.
No, I don't have that much to add. I think within resettlement procedures, countries that are receiving the refugees have their own procedures and their own screenings. I don't know enough about that to say much. My experience from the Netherlands, where I'm Dutch, where I worked with refugee populations, but that's a long time ago, is that it is sometimes quite difficult to predict in the country of settlement, because you cannot always predict how a person will react to the new environment. So that's a slightly discouraging note, but I just don't know. I don't know who asked the question, but I would love to be in touch to explore this further, because it's a rather complicated issue where we have resettlement authorities, we have IOM, the International Organization for Migration, and we have UNHCR, and I think it's important to link these organizations in a better way.
Yeah, so we've got the name of the person. I'll just get their details before we end. Now, I've actually just seen another question, so I think we're going to just overrun a little bit because it seems a couple of other interesting questions have maybe come up. So I'm just catching up with them. So just give me a second. Question here: any updates on the extent to which this topic, primarily MHPSS, is part of the process of the World Humanitarian Summit in 2016?
I hope Mark van Ommer is still here, because he know better. What I know is that, for example, in the run-up to the Humanitarian Summit, there are country consultations, and I know, for example, that in the Netherlands, in February, so last month, a nationwide meeting was held in which mental health and psychosocial support was discussed. I know from several other European countries as well is that mental health and psychosocial support is an important issue and policy makers. So those are those are things. But whether it will be part of the 2016 summit itself, I don't know. Can I refer to Mark? Mark, are you still there?
Yeah, still here. The agenda of right now, the agenda of the summit has been shared yet. It's made by the office of OCHA, UNOCHA. I don't think the agenda is there yet. They are consulting widely, and there have been many consultations in many countries. From that, OCHA will make an agenda. Also, I think from any other forms of advocacy. So I think there is a need to advocate to have this on the agenda for this very important event. It's the first time ever that there will be a world humanitarian top. So this is key. I know that in the Netherlands, humanitarian top, a preparation for the world humanitarian top, this topic was very visibly on the agenda.
Okay, thank you for that, Mark and Peter. Peter, I believe you might have a question on your screen, if you want to respond to that.
I see, if I read it well, a question from Michelle and Kelly O'Donnell. By the way, I think you're in Geneva. And the question is, are any general comments about restoring functionality for this versus healing inner wounds? So what is realistically needed? That's a difficult one. I read the question actually as, should we focus on outcome measures such as restoring functionality, which is involved, could quantify, you can measure it, so of an objective criterion, versus healing inner wounds, which is much more in the inner world of a person, so that will be more of a subjective outcome. And I'm two are contradictory or are necessarily very different. What I think is that functionality in a very mechanical way would not be enough. I mean, if we look at the criteria for mental disorder, it has an element of functionment, but it also has an element of suffering and of suffering stress. So I think good outcome processes should look at both. So both what you can easily measure quantitatively as well as what the subjective experiences of the person are. These are just my first comments, but I would have to think it through better.
For that. Okay, well, we've overrun, so we're going to have to to an end. I'm just seeing another question on the chat, which I can respond to quickly. Just, I'm not sure who this was from, but have buddy systems been used in urban refugee settings? I mean, I know from my own experience that certainly they were used in London, and I wouldn't be surprised if they've been used in different settings. I don't know if you've got any last quick comments on that, whether they've been used in urban refugee settings. No, I don't have enough information on that. What I can say is that body-focused methodologies are increasingly integrated within MHPSS programs, and I think that's a good thing. Okay. And yeah. Okay. So, well, we also had another comment that just said, just a reminder about the very good videos and accounts from refugees on the UNHCR website. So I would recommend that everybody goes and has a look at some of them because they are very good. So, all right. So it's just really left for me to say thank you for attending the Mental Health Innovation Network webinar today. We have further webinars coming up, including one later on this month, I believe, on bipolar disorder. So if you want to listen to this again, or if you want to find out about any of the future webinars, please have a look at the MH Innovation website. Okay, and yeah, thank you all for attending. It's been a really helpful and interesting discussion, I've thought. Okay, so thanks very much, and goodbye. Bye-bye.